Everybody. My name is Jessica. I'm a pharmacist in the ER and a couple other things, but I'm going to talk to you today about advocating for critically ill patients. I want to ask who's here. So, in the room, is it mostly independent advocates? Is it nurses? Do you guys work in an ER or an ICU or a hospital setting? No, primarily no. Advocates. Okay, yeah. Okay. Social worker. Awesome. Okay. Only because it changes, I guess, the tone a little bit, because if it's something you're really familiar with and perhaps you already know all about it, I don't want to put you to sleep. So how do I get this thing to click? Okay. So I'm going to start off with a patient case because that's what we do in school. And maybe this is just my way of, I don't know, putting this on you guys and trauma releasing to you all. But so rest assured, this has been HIPAA removed. This is a true story, but I've changed any identifying patient information here. So we have a patient who comes into the ER, MZ. They're a 72-year-old female. Their chief complaint is that their chest feels funny. So right away, we're going to start cardiac markers, cardiac labs. We're going to start an EKG, and we're also going to take some labs. So what we notice when we check their labs is that their calcium is really high. And when we break it down to an ionized calcium, it is also still really high. Talking to the patient, we find out that they do have a history of renal cell cancer, so kidney cancer. And now the wheels start turning in our heads. Okay, this might be looking something like hypercalcemia of malignancy, we call it. So this is really common in patients with renal cancer or bone cancers where we see their calcium levels go up. And on physical exam and on the EKG, we see that their heart rate is in the 50s, and the EKG is showing that they have a low heart rate, which we call bradycardia. Now, it's not as low as a lot of the patients that we see in the ER, but it's still low. So what are we thinking here? So ultimately, this patient probably has something called hypercalcemia of malignancy, like I said. And so what this looks like in practice is that they wind up consulting the emergency medicine pharmacist, which is me. What this actually looks like is the doctor comes out of the box and walks over to my desk and says, hey, we've got this patient with really super high calcium. What do you think we should do to treat it? I'm thinking about something called IV calcitonin. So calcitonin, there's a little picture of the vial right there of what it looks like, and it's a drug that we use to lower people's calcium in the ER. And when any provider comes up and asks the pharmacist, what do you think we should be doing about this drug? We have to weigh our pros and cons. And so when thinking about IV calcitonin, there's really one main alternative option, and this is zoledronic acid. So when I compare drugs in the ER, I'm looking at a couple different things. For calcitonin, it works really quickly. So I know that this patient's calcium is going to go down relatively quickly, but at the same time, it doesn't last very long. It's only going to last 48 hours. And we also have this effect called tachyphylaxis, which means that with subsequent doses that you administer, the drug actually works less over time. But most importantly, to a lot of us, is that calcitonin is really, really expensive. That little 2 ml vial is $3,200 at cost for us at the hospital, and we charge 5 times drug markup. Now, how do I know that? It's because I can see it. So as a pharmacist, when we verify drug orders in the hospital, I can see how much the markup is. And so for my health system, and it could be different for yours, but this seems to be pretty standard for a lot of the ones I've worked at. When I verify a prescription, I can see what the markup is on that drug. And so for us, in our health system, all drugs are marked up at 5 times drug cost. So for a drug that's $3,200 for a 2 ml vial that only works for a very short period of time, that will lower their calcium now, but not so much later, and maybe will stop working with subsequent doses, we ultimately charge this patient $15,000. That doesn't sit right with me. So that's why we have alternate therapies, right? So zoledronic acid, it works a little bit slower, but it lasts up to 4 weeks. It's a totally different drug class. It's bisphosphonates. They've been around forever. They work really super well. It is in no way inferior to calcitonin. It's just a different drug and it works in a different way. And it's cheap comparatively. Okay, drugs, I hesitate to say any drug is really cheap, but it's $46 for a vial. And so even after 5 times drug markup, the total cost to the patient, before their insurance and before you find out what they actually pay, the itemized bill is going to show $250 as opposed to $15,000. So naturally, you take this to the doctor, right? So you do your research, you come back to the physician who reached out to you, and you say, zoledronic acid works just as well as calcitonin. It's way less expensive. We've got really great safety data. The risk-benefit profile is awesome, and it's going to cost the patient a fraction of what calcitonin would cost them. How do you feel about proceeding with zoledronic acid? And the physician, who you've worked with for a really long time and who you happen to think is pretty great generally, looks you in the eye and says, I am so sick and tired of pharmacy telling me what the cost to the patient is going to be and how much the drug costs. It's not my job to worry about what the drug costs. It's my job to pick the best drug. So it's wrong on so many counts. It's hard for me to know where to start. The first thing that's wrong is that it absolutely is our job to care how much it costs. We might not know how much it costs. Providers often don't know how much something costs. That's perfectly normal. But it's our job to figure it out. And somebody knows how much it costs. And secondly, calcitonin wasn't the better choice here. They were both equally efficacious. It wasn't that they even were choosing the best drug. It was just genuinely that they were choosing what they felt was the right choice, despite the cost to the patient and despite something that would have worked just as well for a fraction of the cost. So, what am I doing here? Who am I? My face on the screen. So I wear a lot of different hats. Something that I do on the internet, because of my own origin story, I was working in the ER in the critical care unit during COVID, and my patients would be asking me, how on earth am I going to pay for this? I have no idea how I'm going to afford this when I get out of the ICU. At the same time, I would go on rounds with other healthcare providers, and we would be saying to ourselves, I have no idea what a 401k even is. What is my contribution match? What am I doing here financially? And so my outlet became the internet. I turned to the internet and started providing free financial literacy information that's easy to understand and accessible to anybody with an internet connection. And a lot of that is patient advocacy. It's how to negotiate a medical bill. It's what to do if you're charged 5 times for the same drug on your hospital stay. But I haven't quit my day job. I still work in the ER, so because I can't let go of the patient. I can't do it. I need to make sure that somebody there cares and somebody is listening, and it takes a team. I am only one of many, but I look at everything in the ER. I joke that pharmacists in the ER are like the man behind the curtain in The Wizard of Oz because you don't really see us, but we're there. We're watching all the time. And I verify every single order that comes through the ER. So everything, whether that's your kid fell and smacked his head and he's getting a lac repair and we're using lidocaine, I'm verifying that. If it's somebody whose blood pressure is, 60/30 and we're running pressors, I verify that. If a doctor puts through an antibiotic that would absolutely wreck your kidneys because the dose is just way too high, I have within my own practice agreement the authority to change those doses before you ever even see them. The end user sees that it looks good and that it's right, but what goes on behind the scenes is a lot more than that. There's a lot that goes on, and I get asked all the time, how often do you see errors that would have really severely harmed a patient? And my answer is every single shift. Every single shift. And it's not just me that catches them, it's everybody. It takes a team. It takes a team of nurses watching the patient. It takes a team of pharmacists. It takes a team of great doctors who really care, and everybody working together. But in theory, that's my job, is to be a patient advocate. We're supposed to make sure that above all else, the drug works, that it's safe, and that it's appropriate for the patient. And so that's supposed to make my job description, in my opinion, a patient advocate by nature. But not everybody loves that. So constructive criticism really is very hard for a lot of people, myself included. I don't think everybody really loves constructive criticism. And so a lot of docs and nurses who my whole job is to follow them around and say, hey, why did you order that like that? Why does the order look like this? Why did you put the dose in that way? How come you ordered it for this patient when it should have been for that patient? Not every provider loves that. So that said, it implies something. It implies something when somebody is following you around and telling you that what you did perhaps is not the most correct. And what it implies is actually, I think, a little bit more philosophical, which is that the provider is not always right. I'm not always right. The nurse isn't always right. The doctor is not always right. And a lot of people don't love that. There's this overarching feeling in medicine that you go into the hospital and people are going to take care of you, and we have to trust them. So many patients are powerless or they feel they're powerless to their care, that they have to relinquish their control and let these people take care of them and just trust that they have their best interest at heart. So this is why patient advocacy is so important, right? Who watches the watchman? The Latin, quis custodiet ipsos custodis. Who guards the guards people? Who is going to be the people that stand up to the people in power and make sure that the end user, the patient, the person who's most important in this whole equation is actually getting the care that they need? And so I am so grateful for all of you who do the advocacy work that you do and that we all do every day to make sure that everybody is watching who needs to be watched, because the nurse can watch the patient and I can watch the nurse and the doctor can watch me. And at the end of the day, who is watching us? Especially when our patient looks like this. Because this is what it is. Our patients come into what essentially looks like an alien spaceship for anybody who's not really familiar with this environment. And there's bells and whistles and buzzers and noises, and everything is horrifying. And who speaks for them? Who speaks for the patient when they can't speak for themselves physically? And so that's what we have to do as patient advocates. We have to speak for them. So how do we speak for them in an alien spaceship when everything is crazy and you're dealing with all the bells and whistles that we just looked at? So I'm going to propose an easy mode 5-step process here that is, of course, never as easy in practice as it sounds on a screen. But these are just some things to think about if you unfortunately find yourself in the ER or the ICU or a family member or a patient or a client or a loved one. Some things to think about that you can take with you when you're having those conversations to make sure that whoever it is getting the care that they deserve. Okay, so here's my easy 5-step process that's never this easy in reality. So step 1 is find your ally, which seems really obvious, but it's hugely important. Hugely important. You have to find someone in your corner, somebody who's going to go to bat for you and with you to make sure that the patient is adequately supported. I think importantly, this can be anybody. It doesn't have to be the doctor. It doesn't have to be the pharmacist or the nurse or anybody. It could be the lab technician or the phlebotomist who comes in to draw the blood. It could be the patient care assistant who's sitting with your patient. It could be an occupational therapist or a physical therapist. It could be social work. It could be nurse case management. It could be somebody who is in your corner, who you know that when you do something, when you say something, they're going to listen to you and they're going to take it very seriously. And it's somebody who you can trust. It's someone that you can establish this rapport with in collaboration so that when you get to the really hard parts later, you have someone who's on your team. And most importantly, if you're not able to do this, if you can't find somebody in your corner, if you don't feel like your nurse is listening to you, if you feel like the doc doesn't care at all about what you're asking, find another provider. Ask for somebody else. You don't have to receive care by whoever is handed to you, although they will most certainly make it seem that way. If you can't find someone in your corner who's listening to your concerns about your patient, find someone else, ask for someone else, request another provider who's going to help you. So step 2 is promote patient safety. There's a lot of different ways to promote patient safety. I think it looks like a lot of different things. I'm highlighting a couple here that I think are really relevant for the ER and the critical care setting. First and foremost, to ask questions. So ask questions about everything. If you see a drug hanging on the pole that you don't recognize, what is that drug hanging on the pole? What is this? What are they receiving antibiotics? Is this fluids? Is it pain medicine? What is on the pole? If something's beeping, why is this beeping? Is their heart rate really high? Is their heart rate really low? Is their blood pressure setting off the monitor? I think people who work in the setting every day sometimes become really accustomed to these noises and they don't think anything of them. But I remember first working in the ER and the ICU and hearing all the noises and being afraid that everyone around me was constantly having a heart attack because they were moving and the EKG wires are messing up the interpretation on the screen. So if you're concerned about anything, ask the question. The next thing I'll say, and I'll go into this in more detail on the next slide, is ensure that the facility uses interpreters and the appropriate translation devices. It's totally unfair to ask a patient or their family to translate their own medical care. It's absolutely astronomically unsafe and unfair.
So disgusting.
It is, isn't it? Yeah. So find out if you have local health systems in your area, find out what it is that they're using. Some softwares are better than others. And I'll talk about why on the next page. But for example, these MARDI devices are really great because they actually connect the patient with a live human being on the other end who speaks their native language and can look at them and talk to them, as opposed to them like speaking into a phone and talking to a robot, or the doctor using Google Translate on their phone. It's so important to pull somebody up who speaks like them and looks like them and can talk to them in their native language so that they feel safe in their environment. And we'll talk about the studies on the next page. And then the other thing you can do is request a comprehensive med review. So again, we're kind of like the man behind the curtain, or the woman behind the curtain, and we want to be involved and we're happy to help. So there are pharmacists not only on every floor, usually CMS is pretty much starting to require them to be on, like in the ER units and on transplant units and that kind of thing, because it's shown how much we've reduced costs and how much we've reduced errors by living in these places. But we also often live in the dungeon, which is close to like the bottom floor of the hospital, and we're in a big central pharmacy. And we're looking at everything. We're looking at everybody's meds, but you might not see us. So if you have a family member or a patient who's in the hospital and you want somebody to sit down with them and take a look at all of their meds, call and ask for the covering pharmacist to come up and do a med review. They would be happy to do that. And they will come up and they will sit down and they will go through every single med one by one and make sure that everything is the way that it should be and see if they can reduce costs or simplify the regimen or so on and so forth. So back to interpretation and why it's so important. So we have a lot of data to say that if patients of limited English proficiency do not receive appropriate translative devices, that 50% of these patients will take part in, witness, become a victim of an adverse event that actually results in physical harm. And of those patients who have an event that result in physical harm, half of the patients who speak limited English have an adverse event that ranges from moderate harm to death, compared to half of those English-speaking patients who experience an event. So we know that patients who do not receive the correct communication that they're supposed to receive in the hospital setting result in more errors, and that those errors are more severe. So make sure that your hospital and your health system has the correct devices in place. Ask them what they have before your patient even gets there, ideally, about how they're going to handle that situation should they confront it. Now, step 3, this is where I really feel like this is where the advocacy like kicks into high gear for me. This is my favorite. So, first and foremost, make sure that the patient's recorded code status aligns with their wishes. So a lot of times when patients get brought into the ER or directly to the ICU, they might be unconscious. Something might get lost in the shuffle, and we need to make sure that the code status that's reflected in the computer is actually what they want it to say. So whether that's do not resuscitate, whether they don't want to be put on a ventilator, feel free and comfortable to ask your nurse or your doctor or anybody who's taking care of your patient, what is their code status in the computer right now? What do you have it as? If, of course, you're the person on record that is able to communicate that information, or that their family member is able to do so. We want to make sure that we're not accidentally providing care that the patient does not want to receive. And I see this all too often where codes get started and patients' chart does not reflect what their wishes are, and things get started that the patient would have never wanted to happen. So it's a huge area of improvement that is as simple as just making sure that the computer says the right thing. The other thing that's really super big is confirming that the hospital has a policy about family presence during resuscitation efforts. So this is really, really big. What do we do? What does the hospital do when a patient comes in and they're having a medical emergency, maybe a cardiac arrest, and we're going to have to be doing CPR? Where does the family go? Where do they go? Hospitals are supposed to have policies about this because of a lot of these studies that actually started in the 1980s. So in the 1980s, everybody started to think, perhaps it's really unethical to not allow family members in the room when we're resuscitating patients. Perhaps it's really unethical that we start doing CPR and the family has to just go sit in a waiting room somewhere and have no idea what's happening with their family member, whether or not they're okay, whether we're doing the appropriate measures or not. And they did these studies where they actually wound up randomizing families to either the group where they were present during the CPR session or they were not present. Of course, they were offered the choice. Nobody was forced to come to the CPR if they didn't want to be there. But what they found, and these were randomized trials, that families that were present, the vast majority of them believed that it eased their grief. They wanted to be there. Most people want to be there. Most people want to be present when their family member is receiving CPR, even if it's really scary and horrifying to see. It lets the patient know that we're doing everything we can and that we're aware of their presence and that we care about their feelings and that they're involved. They don't have to go sit in a waiting room somewhere and find out what's happening to their family member hours later. They can be there. And not only that, subjectively, families who were present also found that it helped their family member for them to be there. They felt that the family member who was having CPR performed felt more comfortable with them in their room, and they knew that that's what they would have wanted. And so this had a really, really major impact. These studies were repeated time and time again. And the families that were randomized to be present had lower bereavement scores and fewer symptoms of depression and anxiety when they were dealing with the loss of their family member. And a lot of hospitals have this feeling, this thought, this opinion, which has been proven to be incorrect, that if the family is present during CPR, perhaps they're going to get in the way. Perhaps they're going to stop something really important from happening. Maybe the nurse will be less likely to do compressions really super hard, where God forbid you might have to break a rib because they're nervous that the family member's watching them. Maybe we'll forget to do epi every 2 to 3 minutes, or maybe we'll forget to check a pulse every once in a while because we're nervous because the family is around. And all of the data has shown that that is not true. It's not true. The CPR is not done worse. The family does not get in the way. The efforts are not reduced in some way, shape, or form. And it hasn't resulted in any legal claims. Because that's the other thing. Hospitals worry if we let the family come in when we're doing CPR, well, what if we get sued? What if we get sued? They don't. We've done thousands of studies, thousands of patients. they've all been stopped early because the benefit of having the family in the room was so profound that they've been stopped early. So the evidence is really compelling. Most of the major organizations that have anything to do with CPR have adopted policies about this, that the family should be allowed to have the option to be present. So check with your local hospital and your health system, what is their policy for family presence? Make sure that there's something clear in place so that if your patient, family member, anybody is put in this situation, that they are allowed to know whether or not they can physically be there. Okay. Another important, very important point is to request a pain management consult. So something that's really big in ICUs particularly is that patients do not have their pain adequately managed. And there's something called a pain management consult. So usually in a hospital, there's a team of pain management people, whether it's a pharmacist, a doctor, a group of nurses, who their main focus in their job is to make sure that a patient's pain is adequately managed, that they're on the correct pain regimen, that their medications are working, and that they're working together appropriately so that the patient is not in pain. I wanted to ask everybody a question I should have asked before I switched the slide. Before reading this, did you think that when patients were sedated or you're under anesthesia right before you go into a procedure, would you expect that they could feel pain? Can you feel pain when you're completely unconscious? Good. It's a huge myth. I talk to doctors about it all day long, nurses, other pharmacists. A lot of people think, and you'll see this a lot in the ICU and the ER, that when a patient is on something like a propofol drip and they're completely unconscious, when a patient is on a ketamine drip and they're completely unconscious, that they can't feel pain. And so we put them to sleep. We put all kinds of tubes in them. We hook them up to IVs. We hook them up to the ventilator. They've got these really hard plastic tubes now in their throat. We put in Foley catheters so they can go to the bathroom. We put in IVs. And a lot of doctors, nurses, pharmacists, everybody think that while all this is happening, the patient can't feel pain because they're asleep. But they can. And what we know is that a lot of these anesthetics that we use to actually put people to sleep actually increase pain perception. So a patient who is under sedation for a really long time in the ICU might actually experience a heightened level of pain than you would if you were conscious.
This is giving me anxiety.
I'm sorry. I'm very sorry. I feel like I should have put a I feel like I should have put a warning in here.
You're the right topic.
So, yes, absolutely. Yes, absolutely. Absolutely. So that's 1,000% where we're getting here. So when you're hooked up to all these bells and whistles, right, there's all kinds of painful stimuli happening. Even just rolling or moving a patient that we have to do every so often can be very painful for them when they're hooked up to all these different devices. And so if they're under sedation, they can't communicate that they're in pain. So we need to use things that can help us tell whether or not they're in pain, scales. And so hospitals use pain scales. Have you ever seen these before, anybody, pain scales? Okay. These two in particular are what we use in the critical care and ICU setting when patients are sedated and they cannot express to us that they're in pain with words. We use these when a patient is on a ventilator, they're hooked up to anesthetics continuously, and we can't ask them, hey, how are you feeling right now? One of the most common ones is the CPOT scale, which is the critical care pain observation tool. And we use these things like their facial expression, their body movements, whether or not they're breathing with the ventilator or they're bucking the ventilator, they're fighting the ventilator to determine whether or not they're in pain. So this is what it might look like in practice. So a patient who's on a ventilator seems pretty straightforward, right? This grimace, the patient is in pain, and so they score higher on the scale. However, what you'll hear a lot in ICU and ER settings is, oh, my patient's agitated. My patient's really agitated. They're uncomfortable. Maybe they're really in pain. They might really be in pain. They might not just be agitated. So we need to make sure that we're using medications like you suggested that actually treat the pain. So a lot of the sedatives like propofol, Precedex, ketamine, which has maybe a little bit of pain properties, but they're not going to treat the pain. Benzo drips, like Ativan drips, midazolam, Versed drips, they're not going to treat the pain. The patient would need something on board specifically for pain, like a fentanyl drip, like morphine every so often, scheduled every 4 hours, every 6 hours. Ask what is their pain regimen. Because they're sedated, that doesn't mean that they're not in pain, and we have to make sure that they have medications on board for their pain specifically. So reach out, request a pain management consult, right? There's usually a team that'll do that. They'll make sure that the appropriate pain regimen is there. And it's a huge part of their job is to make sure that the patients are not in pain. There's all kinds of medications and assistive devices if the patient isn't fully ventilated, or that we can use like patient-controlled analgesia where they can actually choose their own pain management so that they can push a button and receive pain meds when they need it. There's a whole bunch of options, and pain management would be happy to help. Okay, and then request a sitter. A lot of times we put sitters with patients who we worry might be a danger to themselves or a danger to others, but if you have a patient who's lonely in the ICU, somebody who just really wants somebody to be with them and sit with them, consider requesting a sitter, somebody to keep them company so that they're not alone and scared by themselves. Anybody who works in healthcare knows, unfortunately, not everybody gets a lot of company when they're in the hospital. And outside of seeing their nurse and their doctor who come in to like poke and prod them, and me who comes to ask them questions about their meds, maybe they just want somebody to keep them company. So consider that. Requesting a palliative care or comfort measure consult, hospice, that kind of thing. Understand what their wishes are in that department and know that we have people in the hospital whose job is to make sure that they're comfortable if they're not looking to pursue further treatment and they want to just be comfortable where they are. And also, I just want you to know that chaplains and spiritual advisors exist in the hospital setting. Are you familiar with those? Some patients who have, religious or spiritual affiliation and they really want somebody in their corner in that space can come and pray with them. They can come and stop by. And from my colleagues who work with me and in this space, I hear from them a lot that they feel like they're really underutilized and nobody really knows that they're there or asks for them. So just know that they exist and that they're happy to help. Okay, so step 4 is inform your ally. So this is kind of the hard part, and this is probably 50% of my job, where you have to actually say the thing. You have to speak up and say, okay, I've noticed that this perhaps is not how it should be. How do we go about saying that in a way that keeps them on our team and also gets the job done, right? I joke that when somebody's having a seizure and I tell a doctor we should actually do, 60 milligrams per kilogram instead of the 1 gram that you did. I'm not saying that because I think you're dumb. I'm not saying that because, I think you're doing a bad job. I'm just saying it because I want the patient to stop having a seizure. And if that means I don't get invited to their birthday party, I'm okay with that. So we have to figure out, how do we deliver this information in a way that still makes our jobs functional and ultimately affects the patient in the best way possible? Have you heard of this? Have you heard of the feedback sandwich? Have you seen this before? So the concept of the feedback sandwich is that you say something really positive first, and then you squeeze the constructive criticism in the middle, and then you end it with something really nice. So in practice, this might look something like this. I really appreciate all the time and attention you've devoted to my patient and your willingness to answer my questions. I appreciate you. While I have you here, do you think it looks like my patient is in pain? Every so often I notice they make a face that appears to be grimacing. Have you noticed that? Thank you for listening. I appreciate you checking with the doctor about their pain regimen. Okay, so that's the feedback sandwich, right? The data, unfortunately, says that feedback sandwiches are really good at making people like you, but they're not really great at actually getting anything done. People will invite you to the birthday party, but they might not actually help the patient. And so there's actually a better way to do it per the research, and that's to actually directly address the most common barriers to effective communication. So the things that you're worried about, the thing that your patient might be worried about, to address them directly and go from there. So one really common thing that I think a lot of people worry about, because the hospital is so busy and it seems like you can wait a day and a half before the doctor comes in to even talk to you, time constraints. When are we even going to have the time to talk to anybody about any of this stuff, and are they even going to listen? So what the literature recommends is to do two different things: to set aside formal sessions and to have time for real-time feedback. So a formal session might look like, would it be possible to set aside some time to talk about my patient? Hey doc, I know you're running around like crazy. Can I take 15 minutes on your schedule later to talk about my patient? I'm really concerned about their pain regimen. I'm not sure that it's optimized. But it also means that when the nurse comes in the room, when the lab tech comes in the room, to grab them really quick and say, hey, do you mind if I ask you some questions while you're here? And this multimodal method, if you will, is what we've found is the most effective in actually implementing change. So having both formal sit-down sessions and real-time feedback is really important. Another super common fear, especially if you work in this setting regularly and you're working with these people every day, you're going to see these nurses all the time or these doctors all the time, is fear of damaged rapport. If you damage your relationship with these people and they think that you're always just out to get them and you're trying to make their life miserable and really hard, they might be less likely to work with you. And so here, the solution that we see is to set the groundwork early. So whether that's now when you leave here or when it's the first time you ever interact with this person, it's really great to set the standard from day one and figure out if this person even can be your ally right from the beginning and say, hey, will it be okay if I ask you questions as we go along? I want to make sure that I understand everything that's happening here. If this person is not okay with explaining to you everything that happens as you go along, they're not your person. At the same time, we want to speak our feelings, and so we do this because a lot of data has shown that actually if you speak from a place of how you feel as opposed to a more accusatory tone, you can actually get more people on your side. So instead of saying, I think you're doing a really bad job with this patient's pain regimen, I don't really feel like they're being managed appropriately, instead you say, I'm worried that my patient might be in pain. I feel like they might be grimacing. Is there anything we can do to take another look at their pain regimen? Do you feel like it's optimized? So speaking just from your feelings can make a really big difference, and it's like kind of, hokey pokey feely stuff, but it's true. It really actually does work. It's corroborated in the data. Another really common problem, like we said, is an unwilling participant. So this is when you have somebody who just doesn't want to work with you. The solution here is, first of all, to ask their preferences. So what do we need to do to get on the same team? Before you abandon this person as your ally altogether, let's start off with, I'm really concerned that we might have a misunderstanding here. How can we work together? If you find that you can't work together, at that point you get a new ally. So can I speak to a nurse case manager? I'd really like to discuss our options to receive care from someone else. And that's a totally reasonable request. And last, but very much so not least, determine the true cost of care. So I have really great colleagues who are going to talk about cost of care after this a little bit, but just to kind of start the conversation. In other words, what is this treatment actually going to cost? Who can give you that information, and how can you get it? So there's some things to think about. So first of all, a transitions of care consult. If that's something, has anybody heard of a transitions of care consult? So we have teams in the hospital that make sure that when a patient comes in on admission that everything looks correct, and also when they leave on discharge that everything looks correct. A lot is caught in these transitions of care, patients going home on meds that they don't need, patients coming in on meds that they don't take anymore, and a whole host of other things, making sure that they're placed appropriately in the correct location, that they can afford it, that they're safe at home or wherever they're going next. Requesting a transitions of care consult can make a really, really big difference for when the patient leaves and they're out of our immediate grasp. The next thing you can always do is contact the billing department. Now, I talk about itemized bills because as a pharmacist, I see how easy it is for these duplicate charges to happen. We talk about, 50 to 80% of medical bills have errors and we got all these duplicate charges. Why was I charged for Tylenol 150 times? As a pharmacist, every time that I press the verify button, there's a checkbox that shows me that there's a charge. Now, some hospitals do this when they scan and administer the med. Other times it can be as simple as a patient had a inhaler, a really expensive inhaler like Symbicort or Brio in their med pocket. They stepped down from ICU to a step down unit. The inhaler got lost by somebody, and now they're being charged a second time for the inhaler. Or the nurse goes to administer a med, accidentally drops it, needs another one, pulls it from the Pyxis, and we've charged them again. So sometimes these duplicate charges honestly happen out of just honest mistake, because it would take somebody down in the basement of the hospital knowing that the nurse dropped the drug in order to uncheck the box that charges the patient a second time, and a lot of times that communication is just not there. So always check for an itemized bill and always check the duplicate charges and make sure that everything lines up and makes sense. But also, of course, the insurance is huge in making sure that the services that were actually given and that they're correct. And also to remember that everything can be negotiated, including medical bills. People who have lots and lots of money negotiate their medical bills, even though they're full well able to pay for them. And so all things can be negotiated, including medical bills. And last but not least, these financial assistance policies and charity care programs. So nonprofit hospitals are required to have charity care programs and financial assistance policies, and they're required to tell you about them. So if they don't tell you about them, Jared and Erica, you guys are going to talk all about charity care programs, but just know that they exist and that even for-profit hospitals usually have something in place that you can ask about. But know that the bill that they get isn't necessarily the end-all be-all, and that there's lots of things that can be done before they actually walk away paying that final number. So here's all my references in case anybody wants to look up any of these studies, because I'm a mega nerd. And that's everything. So if anybody